Please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
You know what Monday was like when at, I think, 5 o'clock, I asked Joseph to go out and get us a pitcher of sangrias. We don't keep adult beverages in the clinic for a reason, but this lady, she had lumbar spine surgery in 2006. And in the process of that surgery, of course, they did the surgery because they did the surgery on the MRI, which showed a disc bulge at L5S1. However, she had 80% back pain, 20% leg pain, and her pain stopped at her knees.
Okay.
After the surgery, she had nerve pain in her left leg, and he did a left-sided entrance to take the disc out. He pulled the disc fragment out under the nerve root, and he told her, "You have pain in your heel and your foot now because I damaged the nerve during the surgery. Sorry." Okay. That was 2006, so almost 20 years ago.
Yeah.
And then so she's just in a horrible pain level of a 7.
Yeah.
And the rest of her history was like complicated, and she's got asthma and she had atrial fib. So they've got her on some medication that doesn't make any sense, but it took them 2 weeks to figure out what to do to get rid of the atrial fib. So who am I? So I said, look, let's just get you out of pain. That's all she cared about. Pain was a 7. So back to front, that protocol I developed called disc repair for discs that are beyond chronic into gnarly.
Yeah.
Sorry, facet repair for discs that are for facets that are beyond gnarly. So nasty facets.
Yeah.
We call it facet repair.
Yeah.
And then from her low back to her foot, 40 and 396 on one machine, 81 and 396 on the other machine. The thing that caused the search for sangrias was that they told her she had diabetic neuropathies because she also has diabetes. But when she walks, and her leg pain is worse when she walks. When she walks, it starts in her left leg and then goes to her right leg, starts in the feet, goes all the way up. When you test her sensation, L5 and S1 are hypersensitive or numb. L4 is okay.
Yeah.
All of the pinwheel exam on the right leg is completely normal.
Yeah.
And then I showed her the sclerotomal diagram.
Yeah.
I said, does the pain in your legs look anything like these? And she went, yeah, that one and that one. So we fixed the nerve pain, we fixed the facets. That's the good news. The bad news was that the other part of her pain was because her balance is so bad because of the leg pain, inhibition of muscles that make you walk. And when you have nerve pain, you don't have a lot of proprioceptive input because everything's occupied telling you your nerves hurt.
Yeah.
She fell getting off the plane and broke her non-union scaphoid navicular in her wrist. That one. And anyway, so the most pain she had was in her wrist. We set her up even during the history running acute fracture with the magnetic converter. And then, so we treated her wrist a second time for acute fracture. We got rid of the nerve pain, got rid of the back pain. That was the first day. And then the second day, we did her in the morning and then we finally got to the rest of her history. And so she had ovarian cysts and ovarian cyst surgery when she was 14, and a hysterectomy when she was 46 or so.
Okay.
And so I figured the next best thing, run facets again, run the nerve again, get rid of the abdominal adhesions, treat the fracture.
Yeah.
Had what, 2, 4, 6, 7, and a couple of custom cares.
Wow.
So that took care of that. And then remember Brian, the one
Yeah.
that the case report on? Brian is her son-in-law. So
Okay.
family came up, and Brian has, the one thing we didn't get to was a salivary gland under his jaw. And I knew that it would swell up. It has no outlet. The doc that he sees injects the salivary gland with Botox because it blocks acetylcholine, and the vagus nerve uses acetylcholine. And then he ran a vagus nerve repair program and undid the Botox, which I didn't think was possible.
Wow.
So the salivary gland swelled, and it ruptured the night before he saw me.
Wow.
So he saw me in the afternoon, and he said his pain level is a 7. It's okay, that's bleeding. When did it rupture? Between last night and this morning. Okay, bleeding causes pain. So we had 2 machines, one for bleeding in the capillaries and bleeding in the arteries. And then we had spent about 30 minutes thumbing through Netter looking to find out exactly what salivary gland it was, and it was the sublingual one. And there's an important thing about that sublingual salivary gland that we'll get to. So when you look at what would happen if it swelled, if it swells down, it pushes into, he said, when it swells, I get pain up the side of my head all the way up into here. When you look at the muscle that it's going to push on, it's pushing on the digastric.
Yeah.
Yeah, what did I say undid the Botox? His vagus nerve repair protocol, he wrote it himself. Yeah, I have no idea how or why that would work, but apparently it did. So when you look at the digastric, it's all of the muscles in the jaw are connective tissue. So I had one machine just running on torn and broken in the connective tissue, because while the salivary gland is swelling, it's going to push on those connective tissue things and make them tear and hurt. Okay. Then his face was swollen. His cheek was swollen to the point where when he looked out, all he could see was his cheek. He has a little bit of vision in his right eye. And so that was swollen. He had fluid up on the side of his head and then down the face. That means the lymphatics aren't draining. I ran 50 and 40 with 13. The lymphatics, because you want it to drain, and then I took a chance and ran scarring and lymphatics. And as we're running congestion and 14 edema in the lymphatics, the fluid started to drain out. This got all soft, and the right supraclavicular, subclavicular, anyway, lymphatic duct opened up. We did scarring in the duct. And then that left us with this salivary gland that felt like a rock. It was hard, and it was bigger than a robin's egg. If most of us, unless you have a jaw infection, you reach up, you can't feel the salivary gland. And so I reached up and felt it, and it's like, geez, that's hard. So I tried scarring. That didn't work. And I thought, I had a dental hygienist tell me one time, as she, that place where they chip the calcium off your lower teeth and it feels so good. And yeah. Oh yeah, get that piece. And I said, why is there just calcium there? And she said, the sublingual salivary gland has a lot of calcium in the saliva. I don't know what it does, but that's it. And then there are patients who get salivary gland stones.
Oh,
And I went, I wonder, this stuff is really hard. So I tried 217 and the frequency for glandular tissue as a tissue type.
right.
53. Just follow the dots.
Yeah.
And 20 minutes. In 5 minutes, I said, Brian, am I hallucinating? Is that? He said, no, it's getting softer. Okay. So we just kept running it.
Yeah.
Calcium in the sal gland. Pretty soon, his pain was a 2. The salivary gland was completely gone. We were 217 and the duct and scarring in the duct because the salivary gland is so scarred that it doesn't have an exit into his mouth.
Right.
So I ran scarring in the duct and I said, get your finger under your tongue on this side and poke around until you see if you can find a hole. And he did.
Wow.
He said, oh, there's a hole there. Oh, good. There should be. So now so we'll find out tomorrow whether or not it lasts because it ruptures once a week. So that was my yesterday.
Hey, I feel like I have to back up this train. I've been taking notes because it's too much information. It's like, maybe next time when I say, how was your week? You can just say, great, Kim, and how was yours? But okay, that's not why we're here to talk about. But
no, Netter is your friend. That's the only reason we spent almost 40 minutes thumbing through Netter trying to figure out what the salivary gland did. And
right.
They had a 3D cone beam. It took us 20 minutes to figure out how to find the image. And he did have a 3D cone beam and he has no jaw infection because that was the other reason that a salivary gland would be swollen. We had to eliminate that as a possibility.
Yeah.
So we did that. And then it was just us and Netter for 40 minutes.
And let's just talk about that as a quick point. So many of us, I think, feel all this pressure to remember our anatomy, the origin, insertion, action, innervation, and what tissues beside it. And yeah, that's great to have some of that information at our fingertips, but sometimes opening Netter, and I'm a book, you can see in the background, I'm a book geek. I understand there's a ton of very cool software out there, but I have a copy of Netter at home and I have a copy of Netter in the clinic. And there's something it's like using the laminate. It's great to use the buddy when you need to, but it's also great to just look through the laminate and get inspired. So I guess that's the word I want to use, is the inspiration, or getting inspired to have a hypothesis, try the hypothesis, get inspired to look at the tissue. And maybe it's just educating the patient. We'll say, I just want to show you the area that we're looking at. Sometimes I'll just be totally honest and say, I think I'm on the right path, but I want to see what the neighboring tissues are. I just want to make sure I'm not missing anything, because we think about it a little bit differently, more comprehensively as a whole, as opposed to what muscle is there. Then we're looking at nerves and vessels and now glands and so on and so forth.
And they have their own copy of Netter. Brian has been developing protocols for his custom cares.
Yeah.
And he's got the software.
Yeah.
And he's been playing around with it. So with he and his wife both there, we opened up Netter at the sublingual gland. Okay, open it up. Who treats the sublingual gland? I didn't know it was.
Right.
So we together, I said, let's look at this and put the book there. And that way they know your thought process.
Yeah.
And if you're missing something that's important, the patient will tell you. And the patient gets to join in. It helps with we form a team.
Yes, the collaboration.
Yeah.
Yes.
Get you better.
And sometimes when you show them the tissue or you show them Netter, it jogs a story or there's just more information. Sometimes I've noticed somebody be like, oh, I didn't realize that was there. And I remember a while ago I had these set of symptoms. So sometimes it's taking you from nerve pain to a virus or something else down the line. So it can be very helpful for you as a practitioner, them as a patient, and then the collaboration as a whole. You know what I mean?
Oh, yeah. It's how it works. I
And
don't,
I think we talked about it last week about sometimes it's very helpful to have a partner or a parent in the room, and sometimes it's a hindrance to have a partner or a parent in the room. So great that it was a good collaborative experience for all people. I think it can be helpful for getting things like sleep information. I can ask you, how do you sleep? Oh, great, I sleep like a rock. And then the sleeping partner will say, oh my God, they toss and turn and they snore and they get up about 1,000 times to pee. Like it's a completely different set of information that you're getting. I don't mean to poo-poo the partner in the room, but
yeah, the patient from the morning had hypertension
yeah,
and atrial fib
yeah,
and was on like 2 or 3 medications for hypertension. And then there towards the end of, she's had wonderful workups. Kaiser's been great.
good.
She has sleep apnea. So we had that conversation. It's first thing you do when you go home is you get a CPAP. You make an appointment, and her daughter was there in the room with her. So the daughter went into the portal and made an appointment for mom at Kaiser for 2 days after she gets home.
Wonderful.
And then I showed him the website, showed him what face mask is going to work for her.
Yeah.
Because she's one of those people, I don't want something in my face. It's really easy. This thing goes here and it goes around there, and then it's no big deal, and it's better than dying because this stuff is going to kill you.
Yes.
Okay, then. Summer 217 is ankylosis or calcium oxalate.
Yeah.
It's a harder kind because 91 didn't work. So the progression is basically 91 to 217, and then there's actual calcium ions that you have to be careful about using. They're essential in cardiac function and some places in the brain. You don't want to take calcium off. No, you do want to take calcium off in the brain. So 91 and 217 are good in the brain. And then those 4 frequencies on the advanced for calcium ions. In the brain, those are useful because calcium ions go into the cell when magnesium gets knocked off of the NMDA receptor, and then calcium goes in and kills everything.
Yeah.
So that's those 4, which I don't ever remember. They're in the buddy. It's on the laminate. And then salivary gland, we have glandular tissue as a tissue type. And I use it like we have a frequency for the thyroid gland. We don't have a frequency for salivary glands. 53 is salivary gland, and then duct tissue as a tissue type is 21. And so it's what I had. But the good news was I was afraid I was going to have to treat the trigeminal nerve system because there's a branch of the sublingual nerve that comes under here and is part of the trigeminal system. And the frequencies, experimental frequencies we have for the trigeminal system are AB pairs.
Gotcha.
What am I supposed to do with that? That's not helpful. Facial nerve, motor,
Yeah.
I can deal with.
Yeah.
Because there's enough motor sections that all make sense.
Yeah.
AB pairs, please don't let it be the
Yeah.
trigeminal system.
Right.
Yeah.
Oh, now I'm spinning. I want to go in all these different directions right now. I feel like a little
You pick.
dust devil right now. Just spinning.
Okay.
So let's just talk about the AB pairs and just A and B. One question that came up in Arizona that I promised to discuss on the podcast because I figured if this person had the question or concern, many other people did. So we have an A channel and we have a B channel. And we are hoping that A is doing what it's supposed to for the pathology and B is going to the tissue that we are telling it to target.
Good plan.
The question that I had, it was a very good question. So we're talking about, it was the part of the sports course or the rehab course where I talk about not using 13 as tissue is healing. We don't want to interrupt the good scar that is forming. And do you know where I'm going?
Yeah.
Okay, maybe you got asked this question too.
Oh no, just go ahead and finish it.
So we were talking about and then we continued on treating acute injuries. And this person had asked, I treat the lymphatics a lot with an acute injury. I'm like, yes, absolutely, because things get congested and we want to move things through circulation. And they said, but that's also 13. And I said, yes, but it's on the B channel. I said, how does that make sense? How does the body know a 13A versus a 13B? And this is what I channeled like George to come into the room and answer the question for me.
Show up.
Not as well as I had hoped.
Leave you to flop around on your own.
Yeah.
And that's a really good question because because the frequencies mix in the tissue.
Right.
The body really doesn't know, and the two channels don't talk to each other.
Right.
The body doesn't really know which one's coming from where.
Right.
And so I don't run the lymphatics.
Okay, so you just avoid 13 in an acute setting anyways.
Pretty much is if you can get the inflammation down.
Right.
You're
okay. So I'm gonna complicate it just a little bit. So I had this also thought process. So when I'm treating an athlete in an acute condition, sometimes they are getting PRP. And so I can't use 40 with PRP. So I have an acute tissue that's inflamed and angry, and we're doing PRP. And I think I was texting you as I was working with this one athlete a couple weeks ago. I've been using congestion in the fascia. The fascia is everywhere. And I've been using congestion as opposed to treating the lymphatics. And I'm not doing range of motion with something that is so hot, so inflamed, so acute, so painful. But what I can do is whip out my tape measure. So I was just measuring girth to see. So it was the same thing. I'm talking to the patient. I'm like, is it just me or does it look like it's getting better? He's like, sure, feels good. I'm like, I can't measure good. So let's just whip out my tape measure. And then I checked every 10 minutes or so. And I think it was almost like a quarter of an inch. It started to just like deflate. Yeah, if we're nervous about using 13 for lymph, we can use congestion in a ton of different places.
And in PRP, you can treat whatever it is for trauma.
Yeah.
And increase secretions in the fascia and vitality.
Yep.
And
a lot of 124 things are torn and broken, regardless of the PRP or not. Like the mechanism of action is trauma and tearing. So let's not.
Running congestion though makes perfect sense. And
yeah.
I ran across, do you remember? Oh, it was the same year, 22, when you did the Lifetime Achievement Award that I've got back there. I ran across the slides and I sent them to Kevin and had him put them on the practitioner resources, the what I don't teach you part.
Oh,
yeah, that was a tough one when it got to the end. But the beginning part, we eased into the gnarly stuff. But the beginning part was when you see it on the slide, it sounds like a recipe.
yes.
Yeah. This is what you do in this order. And right. But that's around the time that I changed the core and the advanced to teaching it as a thought process.
Yes.
And that's what you're talking about.
Yeah.
If we can't use what's in the recipe,
yeah,
how do I think about it to get done what I need to get done? And that's what I did with Brian. It just ruptured this morning. Ow, it's got it, and your pain's a 7. The only thing that does that is bleeding.
Right.
So I could have treated the nerve, but I didn't have a useful nerve frequency because it was trigeminal. So
You phrase it a certain way, I believe, in the core you're used to. Like when 18 is indicated, it's like bothersome. It cannot be ignored pain. It's something that you can't just get your mind off of. It is this.
And it was between a 7 and an 8 to somebody with great personal pain management skills. So it had to be bleeding.
So with him, this happens quite often. The salivary gland.
Once a week. I had no idea it was that.
When it ruptures, what does that look like? Just a little bit of it, and then it drains somewhere, and then it fills up, and then
fills up this space here. He gets swollen inside in his cheek, up the side. The pain goes up the side of his head. He said, it feels like I have a tension headache in my face and my jaw. And a tension headache. Okay, I have a tension headache here. That said to me, the muscles were tight. Okay,
Yeah.
why would the muscles be tight? The muscles would be tight if when the gland was swelling, it pressed on those, if you look at the digastric, there's connective tissue tendons right under the sublingual gland, at least according to Netter. And it was tension. So if you listen to the patient, they'll tell you what's wrong with them.
Yeah.
I have a tension headache here. What's there? And the only thing that's there is the digastric.
Yeah.
There's a lot of up and down stuff, but the only thing that where he moves his finger from here to there, which is where the gland is.
Yeah.
And we've all 3 of us got Netter open, and I said, it's there.
Yeah.
Yeah, that makes sense. Okay. So it's not a recipe.
Right.
It's the thought process.
Yeah.
And listening and I had no idea that it was happening that often. I thought it was month, week.
Yeah, that is a lot.
And it explains why somebody would use Botox on it to get the acetylcholine from the vagus to stop making the gland, stop producing saliva.
Right.
Does that make sense? You with me?
Yeah.
Okay.
Yeah. So I guess now the question would be, how long will he get relief for? This is something that his salivary gland is damaged. There's a lot of trauma to the area. Will this fix it? Will this be part of a maintenance program? Do we know yet?
This injury happened 40 years ago. And this salivary gland thing has been happening for 20 years. And never in that 20 years did that salivary gland go from hard as a rock to smushy. And everybody assumed that it was because the gland didn't drain because of the scar tissue. But when we ran 217 in the gland, it got soft and smushy. And when I did scarring in the duct, he was able to run his finger under his tongue and create a hole. There didn't used to be one.
Wow.
It's not going to be bad by Friday when he leaves, but we'll write down what to do and see how it goes.
What did you use for scarring? 13? Yeah.
Just 13 and 21. 21 is ductal tissue as a tissue type, and 13 is scarring. I tried 51, didn't touch it, so went to 13.
Yeah.
And I could have, but I didn't think of it, do mucosal tissue in the nose and mouth. So that makes sense.
I know you and I took out the 58s from like the musculoskeletal system because they don't work. Sometimes I have used them as a last resort when I'm pulling out my hair for viscera. And I think they do work well for,
Yeah.
I wonder if the 58s might do anything.
I'll try it. That's the nice thing is if it's going to work, it starts producing softening in seconds,
Right.
10, 20 seconds max.
Yeah.
That was how I knew bleeding was working. The swelling started going down, the pain started going down. He went from a 7 to a 4 or 5 with just the frequencies to stop hemorrhage.
Amazing.
And then the torn and broken in the tendon, that was caused, so basically you had a tendinopathy.
Right.
Think of a partial thickness tendon in your tear in your shoulder and how much that would hurt.
Yeah.
Put it here, that would hurt
Right.
as the gland is swelling. And
Yeah.
then it ruptures, you got a whole new set of problems, and you just have to think your way through those. It was a great exercise. A little bit painful because I had no, please God, fix it so I don't have to treat the trigeminal nerve.
Yeah.
Let's see for it.
I want to go back to, I'm swelling my notes. I was frantically texting as myself as you were going through everything. The patient before Brian that you were talking about with the low back, and then the pain that was diagnosed or categorized as diabetic neuropathy. So can you explain how you were like what diabetic neuropathy pain would have showed up as versus how this patient's, like the differential between the two?
It's a good question.
Thank you.
Diabetic neuropathies are like a sock.
Right.
Now, her hemoglobin A1C is 7,
Yeah.
so it's not horrible. She's
Yeah.
on metformin and glypizide, so it's medication controlled. There are some other things that should be done, but she's 76, and in the medical system, by the time you're 76, they really don't want to do much, just hurry up and die. But she needs to have glucose monitor and a phone, and she may need to be on insulin. I don't know, outside my scope.
Yeah.
You guys figure that out, but somebody needs to go with her to her Kaiser doctor.
Yeah.
And diabetic neuropathies are like a sock.
Yeah.
Nobody had touched her with the $19 pinwheel. So I went down her right leg, completely normal sensation, just prickly, not even hypersensitive, down L4 on the left leg. L4 was fine.
Yeah.
End of discussion.
Yeah.
So socks are diabetic neuropathies, and you start at the knee and you go down, and any place from the ankle to halfway up the calf, they'll go, yeah, that's numb or that's icky, either, and you make a little ink mark, and then you go down the other leg, and if they say that's numb or icky, you make an ink mark on the other leg. Denise, why does diabetes cause neuropathy? What a good question. Diabetes isn't a problem with the nerve. Blood sugar is toxic. Insulin is toxic, but that's another conversation. And blood sugar leaves, I think the technical medical term for it is crud, on the inside of the arteries, and it's the small vessels. So if you look at the part of the core seminar where we've got that diabetic neuropathy section, the pedal pulses are the pulses on top of the foot, just at the ankle, and they involve large and medium size arteries. In diabetics, those pulses are usually normal. It's the capillaries that get gummed up. So that being said, the diabetic neuropathy protocol still uses 62 and the veins and the nerves for inflammation, chronic inflammation, fibrosis, increased secretions and vitality. in the blood supply, and then the nerve last, and it has to be alternating. We found that out in 1998. Has to be alternating, I don't know why. And then you polarize the nerve positive. And usually the numbness at the bottom, that was the other thing. Diabetic neuropathies don't cause pain all the way up your leg. And she says, it really feels like it's coming from my back down my leg. And I said, that's because it is.
Right.
Diabetic neuropathies, your feet are numb. And she said, I can't feel the bottom of my feet. And that's because, oh dear. Okay, I can do this. It's because she has most of her pain when she walks. That is not characteristic of a diabetic neuropathy. Diabetic neuropathies hurt all the time.
Yeah.
It's just, and they're numb. So she goes for a walk, even walks down the hallway 4 or 5 steps. It's her left leg hurts first, then her right leg. Well,
Yeah.
what happens when you walk? You compress the lumbar facets.
Yeah.
So we treated the facets. The nerve damage in her left leg was from the surgery. That was easy. And there was never anything wrong with the right leg except for the lumbar facets.
Yeah, I wanted you to explain this because I think a lot of times we get patients and clients that come in and they will tell you their pain and we talk about their symptoms and then they'll jump to, but my doctor said it's because of this, so I don't think you could help me with that. And it's no. And again, it's continuing to ask the questions and do your physical exam and then connect the dots and then respectfully disagree with why they're having pain. Because if they're given a reason that doesn't really add up, they will also have a solution that is not going to help them.
And it's also really helpful. It's why we videotaped how I do a physical exam.
Right.
And it's now on the website. Thank you, Kevin and David Eakes, isn't it? Is it up? The physical exam, the video?
Yes.
Yes, it's up. So you do
I'm
the,
getting an email about it tomorrow.
okay, and we do the pokey whale exam. And then it's really important to ask the patient, has anybody ever done this to you? Universally, the answer is no. They'll do a nerve conduction study for carpal tunnel.
Yeah.
But nobody does the pokey whale.
Right.
So how do you tell the difference between carpal tunnel and C6 and 7? Carpal tunnel includes the medial side of this finger. 6 is here, 7 is both sides of here, and carpal tunnel is here as well.
Yeah.
And you do a pokey whale exam, and the patient says, oh, that doesn't hurt. Oh, good. Then does this hurt? And you do that. And I said, does that make your fingers tingle? And the patient says, no. It's okay. Then you don't have carpal tunnel. And the patient said, how do you know? I said, then I pick up my phone and you Google Safari.
Yeah.
Carpal tunnel.
Right.
Go to images.
Yeah.
There's a picture of what carpal tunnel looks like. So we do treatment and education.
Yeah, very much.
So I warn patients as I start explaining things, I'm a teacher, and if I'm telling you more than you want to know, you're going to have to stop me, because otherwise, and 100%, I've never had a patient take me up on, no, stop, I don't want to know. It's 100% of the time they want to know more.
Absolutely.
So,
yeah. People don't have the time, I don't think, to explain it, or maybe they don't even know what they're explaining. It's just because I said so, or because my medical textbook printed in 1965 told me.
Or because I've never done a physical exam. All 89, so much of the time, the patient says, no, the doctor never touched me.
Oh, I know.
And then I do this. That's interesting.
Right.
Okay, we're just gonna go on from here because I touch people and do a physical exam because that's how you find out what's wrong. Okay, and Catherine asks, With the pinwheel test, sensation icky or numb should be symmetrical at sock level all the way around for diabetic neuropathy. Yeah, that's how you tell the difference between L4, 5, and S1, because a diabetic neuropathy can be simulated by L4, 5, and S1, except for the pattern. L4 stops at the ankle. L5 comes across the top of the foot and has a nasty spot right in between the first and second toe.
Right.
And then S1 is the heel and the back of the leg. And it doesn't stop at sock level. It
Right.
starts at the knees or higher.
Right.
So yes, Catherine, that's sock level.
I also want to go back to when they were describing their pain. When people say I have pain, is it all the time? No. When does it start? When I move. Do you have pain at rest? No. That can tell you so much of what makes the pain worse. Is it constant? What makes the pain better? So when we're asking people about their pain, yes, I ask them about 14 or 15 questions all about pain, as opposed to what number is your pain? Because on so many questionnaires you fill out, it's the level and the location, and that's it. And that doesn't tell you anything.
Yeah.
Is it always a 5? What makes it a 9?
Exactly. That's it. Gold star. Yep, that's exactly it. Because it's what makes it worse. What she said, it hurts when I walk. Number one, that takes you to the SI joints and the facets. Just that's a clue. And my apologies to everybody that's ever taken the core. These days, anyway, it's all in the core. It's why the core is so
Long.
and there's so much, but it's there so you can go back and look at it. So Catherine, the thing I would suggest is you go to the core slides and look at the diabetic neuropathy section and the whole neuropathic pain section, where we talk about compression neuropathies, carpal tunnel, tarsal tunnel, thoracic outlet versus radiculopathies.
Yeah.
What's the difference? And it's what makes it worse. Oh, when I tip my head forward, when I turn my head, my hands go numb. I swear to you, you are the only one that will ever ask them, when do your hands go numb?
And it's just also like following up with, instead of what makes the pain worse, is what makes the pain. I'm still talking. Something shiny popped up on the questions. And we'll get to it, I promise, because you make that face and we have to stop and look at it. But just as we ask those questions about what makes the pain worse, I think it's just as valuable to ask what makes the pain better.
It's essential.
Yeah, absolutely. So people who are like, "What's weird? My doctor told me to put ice on, but now I use heat." I must have about 14 copies of that book, Ice, The Illusionary Treatment. You could get it on Amazon. I said, here, just give this a quick read. And it talks about how movement and using heat can help decrease pain because there's circulation. I'm not asking these people who are in pain to go out and run a marathon. I'm asking them if movement helps. It does actually. Great. I want you to move more. Let's use blah, blah, blah to help you move more. And then sometimes you get the tricky ones where people are like, it hurts. And then I move for a little while and it's better, but then it gets worse and then it comes back. And then you have to follow up with your pinwheel and exam and passive, active, and resisted testing, and so on and so forth. So,
well, with this nice lady, the other thing you have to rule out when somebody that's 76 with sleep apnea and a history of cardiovascular problems, you have to rule out, okay, when you start walking, does the pain start right away, or can you walk half a block and then it starts?
Right.
Because one of the things you have to rule out with that kind of history is claudication, where they get vasospasm or it's vascular insufficiency. And as they start using the muscles, muscle pain starts when they run out of blood.
Right.
And the thing I remember from chiropractic college is claudication, the pain starts at exactly the same distance that they walk.
Right.
If the patient says, I can walk from the house to the mailbox and I'm fine. If I walk from the mailbox to the neighbor next door, then my legs start hurting.
Right. So lots of questions on pain is the bottom line here.
You need to answer this because
We'll talk. Okay. The question is 67-year-old female that had chronic low back pain in January. She had the nerve severed at L5S1. She developed CRPS. They've had very little success working on her. What are our suggestions?
okay.
Let's get the margaritas.
Yes, this is why we don't keep adult beverages in the clinic. The first question I would ask is, why was the nerve severed? Was it an accident? She had chronic low back pain. How did the nerve get severed? Why did they sever them? Did they sever the nerve on purpose? Was it because she had L5S1 pain to start with? When you cut a nerve, you basically end up with phantom limb pain in that nerve. They call it CRPS. I've never seen CRPS when the nerve was cut.
Interesting. And they just said, yes, on purpose, the nerve was severed.
Okay.
What does that mean?
Why did they cut the nerve? What? Orthopedic surgeons are not pain specialists. Pretty much every pain specialist that I know, it is that when a nerve is cut, you develop basically thalamic pain. It becomes centralized. They call it CRPS. If there's a temperature difference between one foot and the other, maybe it is CRPS. You treat it like phantom limb pain. You just run 40 and 89 from neck to feet or from low back to feet and find a good malpractice attorney. That's it.
Her doctor recommended the surgery. Okay, but somebody still had to do the surgery.
Wow. Okay.
So let's just go through this for a second. Somebody has chronic low back pain. They're 67. Apparently it's happening at L5S1. Pain from L5S1 can be from a variety of causes. It can be from the facets. It can be from an SI dysfunction. It can be from a sacral torsion. It can be from a disc. It can be psoas hypertonicity or hypotonicity, a plethora of problems. So we see L5S1 issues all the time. Very common segment for low back pain. What would make somebody think we just have to do something to the nerve there? Would this mean that the disc showed up fine on an MRI and all the structures are fine except for a nerve? I'm just trying to understand, like,
I'm gonna guess with chronic low back pain, she had a disc bulge at L5S1, but so does 85% of the population.
Yeah.
And the disc was not the pain generator.
Okay.
I just don't know. So I've never, 30 years, I've never heard of that. I've never heard of anybody severing L5S1, L5 and S1 at the spine. S1 does a lot of important things in bowel, bladder, crotch, sac, and you have phantom limb pain in your leg and toe and the back of your leg. And
I'm curious, like, how long was the chronic low back pain? What other symptoms were showing up? What other therapies had they tried? Like, I'm so curious with this.
Yeah.
And yeah, CRPS, let's talk about, again, very complicated, but I feel like it's another term that people are just slapping on people without having a true set of criteria to diagnose it.
Yeah. These days, it used to be very specific. These days, if a patient has nerve pain that you can't fix, doesn't respond to gabapentin, and you can't fix.
Yeah.
They call it CRPS, and sorry, have a nice life. It's just, it's becoming a garbage can diagnosis as far as I can tell.
Okay. Yeah.
Sometimes they walk in with CRPS and that isn't what they have. They have simple neuropathic pain. There's not a sympathetic component. That's unusual. All three.
Okay. So they had it for many years, couldn't sit, sleep, or walk for many years.
But it was all low back pain.
And again, I wonder like what they had tried, and was it just in the low back? Was there nerve involvement down the leg? Was there?
Can't sit, can't stand, can't roll over in bed. That's a torn SI joint. And so there's that.
Yeah.
And the rule in the pain management world is that discogenic pain is 20% back pain, 80% nerve pain. So if mostly what you have is pain in your legs and 20% low back pain, then what you have is a disc.
Yeah.
Mostly what you have is low back pain.
Yeah.
You're going to have 80% low back pain, 20% leg pain, and it's going to stop at the knees. This lady sounds like she had an SI joint. Can't sit, can't stand, can't
So
walk.
now, yeah, I'm curious what her pain is like now. How is the low back pain? And is that a bad question to ask? But I see that all
the surgery would not have changed her low back pain. L5S1 nerve would not develop. But the good news is that her leg hurts so bad that her low back pain is still there.
Yeah.
Her leg hurts so much worse that the low back pain probably doesn't bother her as much. Come on.
And then
give us the next piece.
Yeah, I know. But now I'm wondering, and then so like the part about she developed CRPS. Did she say that? Is this person thinking that? Was she diagnosed with that? And what symptoms of CRPS does she have? Because like you said, it used to be a very specific set of diagnostic criteria, which it's not now. It's someone who's had nerve pain for over 6 months and then boom, you have it. So I feel like we're on a bit of a cliffhanger here, but
yes, we're waiting.
She said, yeah, it still hurts.
She was diagnosed with it, yeah, but
how, right, would be the.
So is 1 foot cold and 1 foot warm?
That is a big one. People who have had just chronic nerve pain, the temperature is going to be the same.
If it's just the nerve, temperature is the same. If it really is CRPS, the sympathetics are involved.
Yes.
And it's the nerve. Oh, the nerve. Okay, the nerve disconnects from the periphery and they cut the nerve.
Right.
Oh my, here's the bad news. Can't put tissue back that's not there. Key to getting rid of CRPS is to get the nerve to reconnect with the peripheral tissue.
Right.
They can't do that. I still treat the sympathetics.
Yeah.
Because there are sympathetic receptors in the blood vessels. Maybe that would work.
Right.
Whoa. I'm really sorry. You're on your own with this one. That one is just ugly. There's wow. Just wow. Wow.
And but this is like a day in the life, right? Of what can potentially come in your clinic. And sometimes I love it when we have the discussions like, it wasn't that easy, was it, what I just did? And then you feel just skeptically happy of, did I do that? Did that work? Is there something more to it? Can it be that easy? And I think we think about that is because when we hear stories like this, where you're just like, I don't even know if anything could help at this point because of the set of circumstances.
40 and 89 is worth trying because basically it's phantom limb pain in the L5S1. And then
but let's try to figure out why her low back is sore. So going back to the SI joint, right? If she's gone through all of this, and to your point, you said it before the person wrote it, she would still have low back pain. When I hear about the standing, sitting, sleeping, I am thinking of the SI joint dysfunction because If you're weight bearing and it's irritated and you're non-weight bearing and it's still irritated, that can tell us a lot. So a really good osteopathic orthopedic exam would be very interesting to see.
The simplest thing with the SI joint diagnosis is can't sit, can't stand, can't roll over in bed.
Yeah.
And that's, so you ask the patient that and they say, yes, and this is what you have, lay down on your back. You shear the SI joint, you bring their knee up, you shear it backwards.
Yeah.
And if they say, ouch, that's what it is. And then you just treat 124 and 77 and 124 on the joint capsule. And
it's a sprained ankle in their low back.
Yeah. Tape their SI joints and tell them it's going to take 6 months if we're lucky.
I also find 124, 783
Yes.
can be helpful. Even 40, 783, depending on how long it's been stuck and shearing and just
Painful.
Yeah.
Yeah.
Gnarly. And then it'll be retraining the biomechanics because you've had one side that was jammed and one side that was loose, and muscles are going to be firing and not firing respectively.
The torn side is the one that hurts. The stuck side is fine.
Yeah.
And you can diagnose it with them just walking down the hallway.
Yeah.
That doesn't look normal.
Is what you say in your inside quiet voice.
Yes.
Your outside voices. I'm gathering some interesting information. Why don't you come back here for a second?
You're such a diplomat. I just love it. See, I can get away with things because of this. I just tell people there's no filter.
Working with athletes, the last thing I want to cause is alarm. So I've learned to keep the catastrophe in my inside voice and have the calm, cool, confident, I'm going to fix this on my outside voice.
And reasonable expectations. SI joints are, I've had both of mine torn, one of them torn twice, one of them torn once. And one was 3 months, one was 6 months, one was a year.
Yeah.
And it just, you keep it taped, you do the exercises, and once somebody tells you why it hurts,
right,
then it just makes sense.
Yes.
Okay. And it makes it less scary. There's two parts to pain. One is how much it hurts, the other is how much you mind it.
That's right.
So
I always have that voice and my Carol voice on my shoulder.
these days I have the Kim voice in my head.
I'm glad we're
Right.
I'm glad we're hearing voices, and I'm glad it's just you and I. It's 4:00. At 4:01 actually, but this was great. I feel like I had my own little personal webinar today. So as always, I love Wednesdays. Thanks everybody for coming and the great questions, and we'll see everybody here.
I'm not going to be here next week. I am going to be in Costa Rica.
What? Amazing.
Yeah, I get to be in Costa Rica next week.
I will be here next week, and I will probably have a guest because I have been talking to a few people, and I sure hope it'll work. If not, I have a lot to say on my own. So
Yay.
I will be here next week. But anyways, everybody.
Week after that, we're doing a core in Portland. So I'm not going to be here the week after that either.
Okay, I will check my calendar and make sure. I have somebody graduating high school in May. There will be a week I think that I may not be here, but I will double check that too.
You go do your other job, which is Mom of the Year.
Oh, I will take that. I love all the jobs that I have, including dog mom. So I don't know if Kevin's going to have to edit the snoring that I very clearly hear on my side with Gray Dog. Name of the book you referred to, Kim? Oh, yes. It's called Iced, The Illusionary Treatment. You can find it on Amazon. It's fantastic. Dr. Gabe Merkin, I believe, is the author, and it just talks about RICE, rest, ice, compression, elevation, how that was coined in the 70s, and how a lot of the data shows that it actually is harmful in repair of tissue. Ice was analgesic, which was great, but as far as helping repair and heal, we have a lot of other better methods for that, including FSM.
Oh, the perfect ending.
Just the perfect ending to our podcast. So thanks again, everybody. And I will see everybody here next week.
See you in a couple of weeks.
Bye.
Bye.
Have fun.
The Frequency-Specific Microcurrent podcast has been produced by Frequency-Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.